Welcome to Week 5. We're moving from descriptive to analytical epidemiology, study designs that can test hypotheses about exposure-disease relationships. The cohort study is conceptually the most straightforward analytical design. You take a population, classify them by exposure status, follow them over time, and compare who develops disease. It mirrors how we naturally think about cause and effect. Exposure precedes outcome. Cohort studies have given us much of what we know about risk factors for chronic diseases. The Framingham Heart Study, following a Massachusetts community since 1948, identified smoking, hypertension, and cholesterol as cardiovascular risk factors. The Nurses' Health Study has informed everything from hormone replacement therapy to diet and cancer risk. Let me walk you through the structure of a cohort study. You start by defining your cohort, a group of individuals who share some characteristic, often membership in a defined population. The Framingham cohort was adults living in Framingham, Massachusetts. Occupational cohorts might be workers in a specific industry. At baseline, you classify cohort members by exposure status. Are they smokers or non-smokers? Do they have high or normal blood pressure? Have they received a particular medication? This classification must happen before disease develops, that's essential. Then you follow the cohort forward in time. This might be months for acute outcomes or decades for chronic diseases like cancer. You track who develops the outcome of interest. At the end, you compare disease incidence between exposed and unexposed groups. Did smokers have higher lung cancer incidence than non-smokers? This gives you a relative risk or, using person-time denominators, a rate ratio. The temporal sequence is the key strength. Exposure is measured before disease occurs, establishing that exposure preceded outcome. This is necessary, though not sufficient, for causal inference. Cohort studies can be prospective or retrospective. Understanding the difference is important. A prospective cohort study identifies the cohort today and follows them into the future. You recruit participants, measure exposures carefully, and wait for outcomes to occur. The Framingham study enrolled participants in 1948 and has been following them and their descendants ever since. A retrospective cohort study uses historical records to identify a cohort from the past and follows them forward to a later time, which might be the present. You might use employment records from a factory in 1980, classify workers by exposure to a chemical, and use medical records to determine who developed cancer by 2020. Both designs follow the same exposure disease logic. The difference is when the investigator enters the picture. Prospective studies allow standardized exposure measurement and complete outcome ascertainment. You design the data collection. But they're slow and expensive, you might wait decades for enough outcomes. Retrospective studies are faster and cheaper since outcomes have already occurred. But you're limited to whatever data was historically recorded, which may be incomplete or inconsistent. Many large cohorts are now prospective, the UK Biobank, the Canadian Longitudinal Study on Aging. They're expensive investments that pay dividends for decades. Cohort studies have several important strengths that make them valuable for causal inference. Temporal sequence is established by design. Because you measure exposure before disease occurs, you know that exposure preceded outcome. This is essential for any causal claim, cause must come before effect. You can calculate incidence directly. You know who was at risk at the start and who developed disease during follow-up. This gives you true risks and relative risks, not just odds ratios. A single cohort study can examine multiple outcomes. You've enrolled participants and classified their smoking status, now you can assess lung cancer, heart disease, stroke, COPD, all from the same exposure data. This efficiency is valuable. Cohort studies work well for rare exposures. If you're studying occupational exposure to a rare chemical, you can enroll everyone exposed and follow them. A case control study would struggle to find enough exposed cases. Exposure classification happens before disease is known, minimizing certain biases. You're not relying on sick people's recall of past exposures, you measured it when they were healthy. For healthcare managers, cohort studies provide strong evidence about risk factors and interventions. When evaluating whether to implement a program, cohort study evidence is generally more convincing than case control evidence. Cohort studies also have important limitations you should understand. Prospective cohorts are expensive and time-consuming. The Framingham study has cost hundreds of millions of dollars over 75+ years. You need to pay for baseline measurements, periodic follow-up, and outcome ascertainment, all while waiting for enough outcomes to accumulate. Loss to follow-up threatens validity. If 30% of your cohort is lost, moved away, died of other causes, stopped responding, and loss is related to both exposure and disease, your results are biased. Differential loss to follow-up is a major concern. Cohort studies are inefficient for rare diseases. If you're studying a cancer that affects 1 in 100,000 people annually, you'd need enormous cohorts followed for long periods to accumulate enough cases. Case control studies are better for rare outcomes. Exposure may change during follow-up. You classified someone as a non-smoker at baseline, but they started smoking at year 5. Do you count them as unexposed? Handling time-varying exposures requires sophisticated analysis. Retrospective cohorts depend on historical data quality. If the factory's exposure records are incomplete or inconsistent, your exposure classification is unreliable. Despite these limitations, cohort studies remain a cornerstone of epidemiological research and provide strong evidence for healthcare decisions. Let me highlight some Canadian cohort studies relevant to healthcare management. The Canadian Longitudinal Study on Aging, or CLSA, is one of the largest research platforms in Canada. It's following about 50,000 Canadians aged 45 to 85 at baseline, collecting biological, medical, psychological, social, and economic information. This will inform healthy aging policy for decades. Canadian nurses participate in the Nurses' Health Studies based at Harvard. These cohorts have been instrumental in understanding hormone replacement therapy, diet, and chronic disease risk. Provincial health administrative databases function as population-based cohorts. Everyone in Ontario with a health card is in a cohort that can be followed through hospital records, physician visits, and prescriptions. This administrative data supports retrospective cohort studies. Indigenous cohort studies are emerging with appropriate community partnership and governance. The First Nations Regional Health Survey provides longitudinal data on Indigenous health determinants. These studies must follow OCAP principles. Historical occupational cohorts have studied workers exposed to asbestos, silica, and radiation. These retrospective studies documented the health effects that led to workplace safety regulations. As a healthcare manager, you might contribute data to cohorts or use their findings for planning. Understanding cohort methodology helps you evaluate this evidence. Cohort data analysis has become sophisticated. Let me introduce key methods. Person time calculations give incidence rates that handle variable follow-up. Each participant contributes time at risk until they have the event, die of other causes, or are censored at end of follow-up. Kaplan-Meier survival curves plot the probability of remaining event-free over time. Comparing curves between exposed and unexposed groups visually displays the association. Log rank tests assess statistical significance. Cox proportional hazards regression is the workhorse method. It estimates hazard ratios, similar to relative risk, while controlling for multiple confounders simultaneously. The model handles censoring appropriately and doesn't require specifying the baseline hazard function. Time-varying covariates allow exposures to change during follow-up. If smoking status is updated at each visit, the model can use current status rather than baseline status only. Competing risks analysis addresses the situation where multiple outcomes can occur, and experiencing one prevents others. If you're studying cardiovascular death, death from cancer is a competing risk. Standard survival analysis can be biased if competing risks are ignored. You don't need to conduct these analyses yourself, but understanding them helps you interpret results and evaluate study quality. Let's summarize cohort studies. The cohort study design classifies people by exposure, then follows them over time to compare disease incidence. This exposure disease logic mirrors how we think about causation. Temporal sequence is established by design. Exposure is measured before disease occurs, ensuring that exposure preceded outcome. This is a major advantage over cross-sectional and case-control designs. You can directly calculate incidence rates and relative risk from cohort data. These are the natural measures for describing disease occurrence and exposure effects. Prospective cohort studies allow standardized measurement but are expensive and slow. Major cohorts like Framingham and CLSA require sustained investment over decades. Retrospective cohort studies use historical data efficiently but depend on data quality and completeness. Administrative health databases enable large retrospective cohorts. For healthcare managers, cohort study evidence about risk factors and interventions is generally strong. When you see a relative risk from a well-conducted cohort study, you can have reasonable confidence in the association, though bias and confounding still require consideration. Next week, we'll cover case control studies, a design that's more efficient for rare diseases and faster to complete. Assignment: find a cohort study relevant to your practice area. Identify the cohort, exposure, outcome, and key results. How was follow-up handled? Any concerns about loss to follow-up? See you next week.